You have been called to review a patient in ICU for a swelling of the arm. The patient is a middle-aged lady who was admitted and had massive IV fluid infusion. At one point, an infusion pump was used to aid in rapid administration of electrolyte solutions. The patient was shortly in ICU and had a left arm swollen and discolored, which was noted. But no further assessment of the extremity was performed at that time. Nursing notes indicates that despite the forearm appearance, peripheral pulsations remains quite good. She was intubated and was heavily sedated. The referral states that the left forearm and hand is massively swollen and in blue now. The hand surgery services are required. On clinical assessment, the massive swelling is noted from the left elbow to the left hand with severe ecchymosis throughout the forearm. The patient was obtunded and no pain response could be listed. Radial and ulnar pulsation are easily palpable at the wrist joint. The entire forearm reflected a rock-hard, soft tissue tensioned. A hospital identification bracelet has been found on the left forearm but is extremely tight and was removed. The automatic blood pressure cuff had been placed in the left arm, had been cycling on and off every 20 minutes to check the patient's blood pressure. The cuff was also removed and relocated elsewhere. It was also noted that there is an IV catheter of 20 gauge in the dorsal wrist to aid in fluid replacement. This catheter has also been removed and fluid now has been seen leaking from the site. Later review, IV intubings and fluid bags revealed that epinephrine-containing solution had been administered through this IV site. Further X-rays of the left forearm and hand showed no fractures or bony abnormalities. There was no gas or contrast media in the soft tissue. Compartment pressures of the dorsal and the superficial border compartment were checked. The dorsal compartment pressure is 131 mmHg and the border compartment is 125 mmHg. Clear fluid begins leaking from both puncture wounds when the compartment pressure was measured. The differential diagnosis here is simply a forearm compartment syndrome due to IV extravasation. There is a possibility of forearm compartment syndrome due to chronic compression as well. Forearm ischemia due to the proximal vascular occlusion, or a forearm muscle necrosis due to the sepsis or localized infections. When there is the extravasation of injuries can have the following four key variables to identify the characters and prognosis. Number 1, volume of material used. Number 2, type of material that is extravasated. Number 3, amount of time that extravasated material has been present, also called necrosis interval. And number 4, the susceptibility of the host to which injury has occurred. Loth et al. Has classified extravasation into 3 types: mild, moderate, and severe, based on the amount of extravasated agent. Mild extravasation present with minimal swelling and pain and represents small volume injuries. No blistering or redness is present in that case. Moderate extravasation area of the soft tissue inflammation of 10 cm in diameter or less. Significant local tenderness and pain is present, although narcotic pain medication is rarely required. Some erythema may be present, but blistering of the skin is absent. Moderate injuries occur due to extravasation of volume about 1 to 5 cc. Again, conservative management like elevation, cool compression, and compression dressing constitute the main form of treatment, although the patient may have residual symptoms up to a month time. Severe extravasation injuries occur when large volumes are infused. Local soft tissue changes like blistering, erythema, and dramatic swelling can occur. Compartment syndrome may result, which would require immediate fasciotomy. In the absence of compartment syndrome or any vascular compromise, specific management of severe extravasation is influenced heavily by the type of extravasated material. The type of agent involved constitute the second major variable to influence the prognosis of the injury. The extravasate agent can be grouped into two different types: vesicants or non-vesicants. Vesicants material that can produce local tissue necrosis. Chemotherapeutic agents are a good example of vesicants like doxorubicin, mitomycin. These cause tissue necrosis. Calcium solutions, potassium solutions, fluorescein, sodium bicarbonate, and radiographic contrast media are also examples of vesicant agents. Many vesicant agents are capable of producing deep level of soft tissue necrosis that may take days or weeks to demarcate. Two particular vesicant agents are of special interest. Vasoconstrictor drugs that extravasate can be particularly dangerous, producing either compartment syndrome or severe local ischemia and tissue death. Local injection like phenytolamine may reverse ischemia and prevent disasters. Ultimate surgical drainage may be required if ischemia cannot be reversed within 3 to 6 hours. Radiographic contrast is another important avasicant agent that can produce local cause of soft tissue ischemia. Obtaining a radiograph of the involved extremity can be helpful in delineating how much tissue is affected. In case where more than 20 cc of contrast media is involved, surgical decompression is usually indicated. Post-drainage radiograph should be obtained to confirm satisfactory removal of contrast material. Non-vesicant material do not typically produce local tissue necrosis, but has the potential to cause significant inflammation. These are sometimes called irritants. Example of non-vesicant agent includes the blood products Valium, methotrexate, and albumin. Most non-vesicant agents can be treated non-operatively as long as circulation is not compromised and large volume evasion is not involved. The necrosis interval has been described as a time between the moment of the injury and the point where irreversible tissue death occurs. Surgical drainage performed during the time interval can dramatically improve the outcome. The necrosis of many chemotherapy drugs is 72 hours, whereas the necrosis interval for vasoconstricting agents and radiographic contrast material can be as short as 6 hours. In case where the necrosis interval has passed, surgical decompression is often better delayed. This is because nothing is gained by immediate debridement, and the area of the dead tissue often takes days or weeks to clearly demarcate. Host factor also influence the prognosis of extravasation injuries. Advanced age, immune compromise, nutritional deficit, steroid dependency, pre-existing peripheral vascular disease are other common host factors that can greatly amplify the damage caused by the extravasation agent. Remember that the mainstay of conservative management is elevation. Using cold compresses and loosey wrap splints are quite effective. Although it seems obvious, make sure that offending or travasation catheter is removed so that no more agent can extravasate, and make sure that the affected extremity is no further compromised by tight special dressings or a jewelry or hospital identification bracelets or tight bandages. Heat to the affected area makes the local swelling more worse and should be avoided. Marking the affected area with an ink marker so that improved or worsening can be easily identified is also important. Surgical intervention is an immediate requirement if compartment syndrome or compromise of major vessel is present. Surgical drainage and decompression of an extravasation injury is also helpful if large volume of agent are involved, or if the offending agent is vesicant and the local necrotic interval is not yet expired. Once the interval has passed, surgical intervention may be better delayed. In our case, the patient was taken to the operating room immediately for emergency fasciotomy. A dorsal longitudinal incision was made from the lateral epicondyle to the mid-carpus, and a dorsal forearm fascia was completely released. A palm incision was then performed from the antecubital region to the mid-palm in the hand. Laceratus fibrosus was released, as well as entire forearm fascia. The deep water compartment was also explored, and the fascia overlying the deep water muscles was also released. Distal carpal tunnel release was also performed. Upon the release of these compartments, 250 cc of clear fluid was drained and sent for the labs as well for analysis. Suggested it was a mixture of plasma and electrolyte solution. Neither dorsal nor palmar, forearm, or wrist incisions could be closed primarily, and was not attempted to make so. Post-operatively, the patient returned to the operating room multiple times in the next 3 weeks' time with wound debridements. After the surgical swelling subsided and the wound was stable, meshed full-thickness skin grafts were applied for soft tissue coverage. Our case does show that the presence of peripheral pulses does not exclude compartmental syndrome or suggest that severe local soft tissue injury is not present. Although it may seem obvious, the infusion should be turned off and IV catheter removed immediately once the potential extravasation problem is identified.